everybody. Hello, Dr. Ahmed. Is my voice clear? Should we start our webinar or wait for a little bit? Dr. Ahmed, are you hearing me? Hello?
Okay, doctor, let's start.
Okay, Dr. Ahmed, thank you for this opportunity. I'm happy and honored to be with you today for this webinar powered by MGM Germany and AG Global Egypt. Let me first introduce myself. I'm Dr. Mina Magdi Fikri, an Alexandrian prosthodontist that practices implant dentistry since 12 years old, since 12 years now. It has been my passion to dive into implant prosthetics from the very first day in implantology. And today we will explain some tricks, tips, and the things that everybody should know about prosthetics while practicing implant dentistry. Okay, let's start our lecture with an icebreaker. Let the people gather, a deep dive into implant history or introduction of the implant. We will discuss today the topic of
Doctor,
implant
excuse me.
introduction.
We need you to raise your voice, please.
Okay, I'm raising my voice. Is it more clear?
Yeah, that's okay. Thanks.
Okay, okay. Let's break the ice with some implant history. We will first start with implant dentistry introduction, consideration in implant prosthetic workflow from single to multiple restoration, planning for segment and full arch implants, implants, multi-unit accessories. And finally, we will have some cases for discussions. So throughout the history, we have seen many attempts for prosthetically restore the teeth, the missing teeth. It all started prosthetically, only prosthetically, as we see in the photos, the trials for prosthetically restoring missing teeth from different civilization and eras. Then with the introduction of surgery, before Amproapari, there was Al-Buqaisis or Abul Qasim al-Zahrawi, who introduced surgery in the Arabic world. But the father of the surgery we consider to be Amproapari, which who introduced the modern era of surgery. From then, we have changed our perspective about implants or prosthetic as a whole. It always goes on surgical or comebacks to prosthesis, or we now do a mix of surgery and prosthesis and periodontal surgeries to get the best results we have. In 1793, John Hunter introduced tooth transplantation. It's considered a type of implant that is used till now, but of course with new innovations and new literature reviews and other. In 1807, Magiolo described the implantation made from gold carat, gold 24 gold carat. It was like that. He introduced this implant. It was put into the socket by only friction. In the first 1900, Baer described a tooth replacement that was made from tooth-like implants. It's today has been reintroduced by using the digital methods, using zirconia, but in their days they were using metals to replace the tooth. Greenfield described the first modern-like implant. It was called the basket implant. Implant was made about for a basket, and the prosthesis were landed on its implant by friction. There is an implant like this today. It's not the same design, of course, but of course, you know, the Bicon implants still had prosthesis that is going on the fixture with friction only. In the US, in the 1938, Adams exclusively described a two-step implant. Two-step implant, it's like that we use nowadays, but it faded and got lost in history because the osseointegration protocol was not yet introduced. But surprisingly, you can see the implant he introduced in the 1938 is much like that we use today, a two-piece implant that he invented before Primark 40 years. Also, this type of implant that faded in history and then got reintroduced today using the innovations of digital dentistry. Gustav Dahl introduced this implant. We call it juxtaosseous implant, or nowadays we call it periosteal implants, subperiosteal implants. And then we have the historical gathering in Italia, Milano, for the first who use implants. They uh, they showed in this gathering or conference an osseointegrated implant, but before knowing what osseointegration was. Then in the 1950s, Pierre-Ingvar Remarque has his famous experiment on rabbits where he was using screws for fractured bones. And then he discovered the osseointegration concept first in the literature with case series. Then it got popular and very popular. Even he was nominated for a Nobel Prize. He was the only one related to dentistry to be nominated to Nobel Prize till now. The statement is patients from the dawn of history come to our practice seeking restorations, teeth, not implants. The teeth you are offering for them, it's either uh, by surgical means, by prosthetic means, or etc. But they are not coming for implants, not coming for surgeries, not coming for periodontal plastic surgeries. They are coming for restorations, teeth that are aesthetically pleasing and functioning uh, with a good function. So with the introduction of the modern implant dentistry, the root form dentistry, the root form implants with Pierre Ingvar and Nobel Biocare and extra many companies have introduced their implant system since then. We have stated many problems, prosthetic problems. Prosthesis is a branch from implant dentistry. Implant dentistry contributes from three branches: surgery, periodontal surgery, and prosthetic. rehabilitation or prosthetic restorations. Prosthesis is yet the most neglected part of implant dentistry, but it is the most stated and the most predictable part of the implant dentistry. You can put your implant, make your implant surgery, and wait for your implant to succeed in osseointegration or fail in osseointegration. You just pray till that happen. But with prosthesis, you have everything under control. Yet the failures always happen in the prosthetic part or in the prosthetic restoration. And in the literature, the failures after prosthesis are much more than the failures before introducing your prosthesis or loading your implant. So we can segment our problems in the modern implant dentistry regarding the prosthesis into this category: position-related problems, angulation-related problems, restoration-related problems. These problems can happen in single implant, segment implants, and full arch implants. Also, these problems can happen in the impression step, the restoration step, or the insertion of the restoration step. To sum up our techniques, I would go fast on this. Impression techniques, it can be direct abutment level only, or indirect abutment level or implant level. This is direct impression technique. You treat your implant just like a prepared tooth. You can take an impression, but this is largely unaccepted today in modern implant dentistry or in modern implant prosthetic workflows. It has many problems with the fitting of the crown afterwards, because you are going to pour this into a gypsum cast, stone cast. The stone cast has expansion. Then your crown will not be fitted on your implant. Also, with this workflow, you are bounded to use cement retained restorations. You can't use screw retained restoration using direct abutment level techniques. Indirect abutment level or implant level, you can have indirect impression on the abutment using a pickup, or you can record the implant level using the closed tray technique or the open tray technique. And of course, you can use the new digital techniques. Also, the abutment level impression, we use this term to describe the impression made on multi-units. So when you see in the literature an abutment level indirect impression, you can expect to see a multi-unit impression. In the restoration, we can have either a screw retained restoration or a cement retained restoration. A screw retained restoration, you can have a true screw retained restoration. We will know how to do it and when to do it. And a screw-mented restoration, that is the restoration we do on tie base and cement it on the lab or in the patient mouth afterwards. Or you have screw retained restoration on multi-units. For cement retained, we have cement retained restoration on a stock abutment or a cement retained restorations on custom abutments. This is a diagram. This you can see here a true screw retained, that is porcelain built on a metallic base, or a screw-mented restoration, a tie base with a prosthesis, and then they are cemented outside the patient mouth and get screwed on the implant. Those here are cement retained on stock abutment or on custom abutment, and we will know when to use custom abutment afterwards. Insertion, we also have problem insertion with the screw retained restorations and cement retained restorations. To sum up what we have, with the screw retained restoration, the issue is always about passivity, the path of insertion of the restoration. The cement retained, we have problems during insertion, which is the issue of periscementitis or the issue of loose crowns. Insertion for screw retained restoration is bounded by many factors. You can expect that you will shift your prosthetic workflow due to implant position. Also, with screw retained restoration, it differs a lot from single. You are restoring a single implant or restoring multiple implants. Implant angulation also plays a role in your screw retained choice of prosthesis. The type of abutment or accessory used, like this case, we have full arch implant case. This is you should choose the appropriate abutment for landing your screw retained restoration safely and passively. Of course, in this case, the angulation played a role. Here, it's not the best choice to choose screw retained restoration because the screw channel exits in the buccal side, and this is considered an aesthetic failure. In this case, the angulation prevents you to land your prosthesis because you fail to choose the proper implant prosthetic accessory and use the stock abutment with implant angulation that prevented you from landing your prosthesis. Prosthetic problems are what we say position related problems, angulation related problems, type of restoration related problems. These problems will correlate to our three main steps: impression, restoration, and insertion. Let's begin with the position related problems in single implants. Problems can be described in 3D planes. They can be either apico-occlusal like this, deep implant, or superficial implant, or they can be buccolingual like this. You have a buccally positioned implant or a palatally positioned implant, and we will see cases for this. Or a mesiodistal implant. You have a mesial implant or a distal implant. This must happen in the molar area. Position mostly describe the 3D body placement of the implant as a whole, not the angulation also. The whole body of the implant is shifted toward a plane of our planes. So let's begin with the deeply positioned implant. The deeply positioned implant is one of the vertical implant positions. You can have deep implants or superficial implants. We will not talk about superficial implants because superficial implants needs perioplastic management for their treatment, and they always face problems in the prosthetic part. We can't solve them prosthetically. We solve them periodontically. So we will speak about the deep implant that we can solve some of the problems we can solve prosthetically. So the first, this is my case. The first step is impression. In the impression of the deep implant, you will face a problem using the normal direct technique. You can't use direct technique because the abutment will emerge only 2 to 3 millimeters out of the uh, of the of the periodontal crest of the gingival crest. So you can't have direct technique. You also can't have a digital technique in most of the cases because the area that needs to be scanned will most probably be under your gingival margin. Also, you will face a problem with a closed tray impression because a closed tray impression needs to be embedded in your impression afterwards. And the emerging part from the gingiva is still uh, too short to be embedded with the same direction. you may have a wrong impression. So I guess in deep implant, your only choice is to use the open tray impression technique like we do there, we do here. Then in the manufacturing step, your only way to do it is using a custom abutment, or you can use a screw retained abutment, a custom made screw retained abutment using the newly offered uh, castable abutment, or the pre-milled abutments. We will see cases with pre-milled abutments afterwards. So in this case, we prefer to use the custom abutment. We made a custom abutment with a long cooler, and we cemented it outside the patient mouth, and then we introduced this restoration without having a problem for perisymentitis, without having a problem in the impression, and etc. So other case, this case where we have custom abutment and a cement restoration on top of it. So to sum up our deeply positioned implants, prosthetic management by custom abutments or screw retained prosthesis. You can leave it as a sleeping implant if you don't need it. You have other implants, or you can choose to remove this implant if it is severely malpositioned. Buccolingual malpositioned implants. We won't also speak about the buccal position implant because the treatment of buccal position implant requires a perioplastic management, and they are mostly to be removed, not to be restored. Let's take an example of palatally malpositioned implant. You can see here the case. This is my case. The implant looks fine from this view, but from the occlusal view, you can see how palatally it is. You are thinking about many prosthetic options here, but the main concern here is how are we going to have this cantilever without breaking or de-cementing of our restoration? And how are we going to evade the bulk of the restoration that will be here? The patient won't accept the bulk of the restoration that will be here in the palatal area. So this is the final result. Let's see and go through how we managed this palatally malpositioned implant. We choose to use a pre-milled abutment to make an abutment with the least height on the palatal area. And then we will restore this by porcelain. It's porcelain fused to titanium. You can see here how it's flushed, seemingly flushed with the gingiva. If you use other type of restorations, we need at least a 4 mm of abutment or of a tie base. There is no tie bases that is lower than 4 mm, or it gets de-cemented. You can see the restoration here and from the other side. And this is the final X-ray. I guess it's acceptable. This is from the occlusal view. The lowest profile you can do for this area is using the pre-milled abutment to make this custom abutment. So to sum up our management for buccolingual malposition, with severe malposition, it's always implant removal, mild malposition buccal, soft tissue grafting, and cement retained restoration. palatal malpositioned implant, you can use a true screw retained restoration. Mesiodistal malpositioned implants with single implants, we are bounded to use a cement retained restoration on custom-made abutment. Why? Because if you use the stock abutment, you will end up with having a pseudo pocket here in this area. If you want to make a screw retained abutment, you will have a problem with the path of insertion. So the most sane thing to use is to choose the cement retained restoration on custom abutment. Custom abutment, as I said, they were made in the past. We would made them from the USCLA abutment or a castable abutment. Nowadays, we use the pre-milled abutment. Let's go to the other problem we have, the angulation-related problems in single and multiple implants. Angulation-related problems in single implants, they start with your planning. With your planning, you should know if you will have this problem from the first place or not. Sometimes you are bounded to have this problem to put your implant in a good bone. You will have to accept this angulation problem and solve it with other things such as an angled abutment, angled stock abutment, or even a custom abutment. In multiple implants, you are going to solve these angulation problems with many other options we will see in them later on. The the thing that you have to know here is the planning from the first place makes you know what to use in the prosthetic phase. So do not let your prosthesis for the prosthetic replacement period. No, you should do it in the planning period. We call it crown down technique or prosthetic plan, pre-prosthetic plan. Also, we have angulation problem in multiple implants. You can't use the closed tray impression techniques because the impression will have tearing while you are removing it from this tray. You also need to have another accessory, which is multi-unit, and we will know it later on. Okay, let's speak about implant angles and screw retained restoration. With screw retained restoration, you have a problem in insertion if the angle is not parallel. You can have either parallel. With the parallel, you can use a hex prosthesis, but no one have this 100% parallelity. So it's theoretical to use a hexed abutment for multiple prostheses. Or you can have non-hexed abutment or rotating abutments. Also, you can use a multi-unit. A multi-unit is like going back in history for the Nobel Biocare Pranamark implant. It was external connection, and then we know the external connection uh, accepts more angles. You can have an angulation of 16 degrees or a less more in implants with cone and hex. This with implant with hex only. With a 16-degree angulation, you cannot land your prosthesis with hex. You can do a non-hexed prosthesis or use a multi-unit implant without correction of the angle because multi-unit accepts angles till 30 degrees. Or you can correct your angle. It's your choice. Use a multi-unit with angled abutment, angled multi-unit abutment. The degrees of angulation increases, you have less options of screw retained prosthesis. Exceeding 15 degrees, you are bounded for multi-unit prosthesis only. You can't use the non-hex. You only can use the non-hex won't work in this type of angulation. You only have to use a multi-unit, either two straight multi-units, or you can slightly fix your angle with a 15-degree multi-unit. Notice that they are 24 degrees of angulation, but I only used a 15-degree multi-unit because the multi-unit we use, the straight multi-unit accepts to 30-degree. So here we can use either two straight multi-units or one straight multi-unit and a corrective multi-unit with 15-degree. Let's increase our angle more to 30 degrees. Now, even the straight multi-unit will fail to accept your prosthesis, or you can't lend your prosthesis passively using two straight multi-units. You are bounded to correct your angle with an angled multi-unit. So do I need a 30 angle multi-unit? Actually, no, you can use only 15 and you can use your 30 angle multi-unit. Okay, here we are correcting the angle with a 30-degree angle multi-unit. They are now parallel. So why did the companies introduced the 30 multi-unit, 30 angle multi-unit if the 16 or 15 multi-unit will be enough here in this situation? Because in other situation we will restore full arch, we will have degrees more than 30. The degree between the two terminal implants, if they are uh, put in the all-on-4 fashion, will be more than 30. They can reach 60 or even 80 degrees. Like this, when you have four implants, two tilted implants, terminal implants, the degree between this implant and this implant will be 60, not 30. So you can fix it with two angled multi-unit on each terminal. Also, the anterior implants in all-on-4 bridges or restorations may also have angles, but not in this plane. They have angles in the buccolingual plane. Let's see cases of multiple implants. These are two implants. They seem from this view to be absolutely parallel, but they are not, because in the other plane they are not uh, perfectly parallel, not 100% parallel. So we choose to use one hexed abutment and one non-hexed abutment, and then we landed them safely and passively. In full arch restorations, we have another consideration. Of course, the time doesn't allow us to go deep in these topics, but we have an overall view of all prosthetic options. Anatomical consideration, you have anatomical consideration for the maxillary arch and anatomical consideration for the mandibular arch. That prevents you to put your implants in the desirable position prosthetically and force you to put your implants sometimes with angles. Even if you want to put them parallel, the maxillary arch, for example, is conical in shape. So your implants by default are not parallel. If they are parallel, they won't touch each other on the plane, but they always, when you extend a line, you can see that there is a conofacial figure of the maxilla. Prosthetic consideration, we divide the maxillary or the mandibular arch into three segments: the posterior segment, the canine segment, and the anterior segment. When you are restoring a full arch, you need an implant in each segment to have a perfect prosthesis. These segments, if we saw deeply of them, you will see that putting an implant in posterior segment will always have a different angle from putting an implant in anterior segment. So in full arch restoration, full arch implant placement, you will always have angles between your implant, even if you intended to place them in a straight axial fashion. Like this, we can see the implants are in the maxillary arch. They are in the X-ray a little bit parallel, but in the real world, they are not parallel. We have used an angled abutment here, angled abutment here, and an angled abutment in the anterior also, because they are facially inclined. The lower arch, we use two tilted implants with angled multi-units and two straight multi-units for the anterior implants. The multi-unit connection is the secret word in the full arches restoration. Another example for ensuring that you all will always have angles is the prosthetic part for the multi-unit. You will always find uh, your open tray impression technique for the multi-unit and will not find the close technique for multi-unit, or rarely find a close technique, because the companies have advisors that tell them always with multi-unit you will have angles. So close tray is not needed with multi-unit restoration. So many companies neglect manufacturing a close tray impression posts for multi-unit. They only manufacture an open tray for their multi-unit impression techniques. The digital era and some cases, you can see here a single implant with a direct impression. This is in a good position, the direct impression, and then the landing of a cement retained restoration. You can have something we call a scan body. This is a scan body on tie base. The other one is the multi-scan. You scan your abutment outside the patient mouth and then rescan it to allow your lab to see the finish line. You as if made your own scan body. Another case of position. If you put your implant positionally correct, you solved many problems. You solved 90% of your problems. Scan body, and then a screw retained implant. This case that I showed you before. Scan body, screw retained implant. Full arch case. This is a case of FB2 or maybe an FB1. In FB1 or FB2 cases, the greatest thing you do to your lab or to your patient, is to put your implant on put your implant to restore each tooth prosthetically correct. You have a molar, you have an implant inside this molar. The implant for a canine, implant for a central. You do not put implants in between teeth, because with FB1 restoration, it is not permissible to put implants in any other places than the normal positions of your teeth. This is something called an optical pathway for old. Uh, this is now is considered an old scan body. The big scan body is not the best to use. Our scanners struggles with this type of scan bodies, with this type of big scan bodies. It's hard to be scanned. We will see other cases with other type of scan bodies. Also, in the digital era, you can see what you are doing. You can have your job done with a guided surgery, no guesses, no intuitions, no good intuitions. Everything planned is to be done in the surgery. This case was done with guided implant surgery using a real guide and MGM implants. This is the modern or my everyday workflow nowadays for full arch restoration with immediate temporization. You can see this case, we're seeking a full arch upper maxillary restoration. You first can see your 3D cone beam CT to decide which implants are going to be used and the angulation of your implants. Of course, here we got abundant soft tissue, but the hard tissue was a problem. We don't have a thickness of bone, so we choose to use the palatally approach, old school, old school drawing for your implants. You know, here the implant size, the drill. I'm going to drill 13 millimeters. Here I'm going to drill 15 millimeters. The protocol, this is a normal protocol, and the other left side or palatal protocol. Also the multi-unit. I used to choose my multi-unit before surgery because when you are intending to have angled implants or so, you need to enter your surgery with your angled abutment to see if your angle uh, is corrected correctly or not corrected inside the surgery. You won't know that afterwards. These are our implants as planned with two angled abutments here and here, and the other four implants with straight abutments. This is my daily protocol. Implants, and then scanning. You see here the scan body of MGM. It's low profile scan bodies, metallic low profile scan bodies, which make your scanner run very fast on them without needing of stitching or extra. Another scan bodies was introduced in the market lately, which have the horizontal scanning protocol or central scanning protocol, and this make our life easier other than the old big and tall scan bodies, they were hell to use. But these are easily used. You know you have no stitching, no stumbling in your optical path. You know you have a good impression. Then you send it to your lab, put your multi-unit healing abutments, and your lab delivers a prosthesis the second day. This is a very important step to assure that your lab have had a good superimposition, a good matching for your scan. With this heat map, when you see a blue heat map on the upper surface of your scan body, you are rest assured that your implant prosthesis will be good and passive and won't have any problems. And luckily, that what we had in this case. This is 3 days after surgery. We remove the healing caps and land our prosthesis safely and passively. And this is the before and after pictures. A happy patient, a safe temporization, and you have no other problems, no welding, no intraoral welding, no others. Just take a scan and the lab will do the rest. I call this the Rolls-Royce of temporization. And this is what modern dentistry we have reached till now. We finished our lecture. Questions are welcomed. If you want to ask any question about any case in the lecture or anything in the lecture, you are most welcome.
Thanks, doctor, for this great lecture. It's a great time for joining this lecture with you, and hope you the best for the future with MGM. And let's enjoy with your cases for online.
Thank you, Dr. Ahmed. If there are any questions, it's most welcome.
I'm waiting for the attendees for any question, but no one raising his hand. That's mean everything is okay.
That's good.
Okay.
That's good.
Thanks for your time, doctor. It's a great
Thank
lecture.
you. Thank you,
Thanks for your
Dr.
time.
Ahmed. Thank
Thanks.
you.
Bye-bye.
Salam.